Good afternoon, everybody. Thank you very much for joining us today. A little different and a little special webinar today as we are doing a fireside chat, how Northwell Health drives quality excellence across practices and programs. There's going to be a lot of opportunity at the end for some questions from the audience, um, as well as a chance to review the slide deck afterwards when I email everybody. Today, I'm going to be joined by three colleagues from the Northwell side. Say hi to Ramsey, Aman, and Jared. Hey, guys. And my sidekick here at HealthMonix, Wallace Jones, will be joining me as well. Logistics, you can ask your questions in the little box up at the top with the question mark. If we have an opportunity to get to them at the end of the call, we will. Otherwise, we will send the messages to whomever you are saying needs to see it, and we'll try to get those answered to you in a short period of time. We also have just a small presentation in the beginning to kind of review what we're going to go over and how this is going to work that you can also see in the attachment sections. And then once again, at the end of this webinar, you'll have the opportunity to review this. We will send this in an email shortly afterwards so you can take a look at it or share amongst other people of your organization. So a couple things that we're going to do. So today we're going to review operationalizing, that's a big word, quality across practices. We're going to look into drug improvement as well as how do we prepare for really 2026 and beyond. What did we do in 2025? How are they going to work towards the finish line for 2025 reporting in Q1 of next year? And then, what does the future look like? The final rule just was released last week, which introduced some changes to things. We'll have an opportunity to discuss, what it looks like with those changes, as well as how both HealthMonix and Northwell are adapting to anything that may come in the future. So without further ado, I am going to pass it over to Ramsey to give us a little background on Northwell and where we're at right now.
Thanks, Mike. Appreciate the opportunity to share the Northwell story here, and very excited to talk about some of the work that we're doing to kind of help level set some of the work that we're undergoing. We felt it was really important to provide a background on Northwell as an organization. On this slide, what you can see is we are really a sort of New York-based health system, and we've expanded recently into the upstate region of New York as well as Connecticut. And we are really representative of two sort of geographies, a very urban geography based out of the greater New York City area and a bit of a suburban area. And really our goal is how can we establish a singular framework around quality improvement, covering this very large and diverse geography. And as I mentioned, our recent expansion into the Connecticut and upstate region has officially made our ability to do quality improvement a little bit more challenging, simply because it's kind of difficult to travel the distance that we have to travel and touch on all the different practices that we have to do. So we're constantly thinking about how do we keep the standard while also being flexible and adaptable to the local geographies and practices that we work with very closely. And on the next slide, I'll talk a little bit about some of the work that we've done to establish a framework for quality improvement that we use in the ambulatory setting. We published this framework in different medium, but we call this the Ambulatory Quality Improvement Collaborative. The idea was, how would we institute quality improvement across this large geographic and diverse health system that I referenced? And what we realized is we didn't really have a structure in place. A couple years ago, when our new Chief Quality Officer, Dr. Barron, joined our team, she really wanted us to think about this more holistically, more systematically, but also to think about how do we, again, allow for local adaptation. So this framework was born sort of out of the need for us to figure out how to do this work at scale while also allowing for those local adaptations. So we created something called, as I mentioned, the AQIC, and then we kind of flex and adapt the AQIC based on the different needs. As you can see, we have what we call a lot of horizontals, or a lot of these work streams. Depending on the type of quality improvement initiatives that we're working on, we might activate some of the work streams, or some of them might be more involved versus other. Really good examples, if you think of hypertension, there's a lot of clinical management. So within the hypertension umbrella, we'll do a lot of the management clinical work under those specific realms. Think about, protocols to treat hypertension, medication management, et cetera, versus say something like depression screening, where there really isn't as much clinical management involved in that work, but more so operational implementation, where more of the work will be lifted up in the implementation side. So depending on the initiative, we really created this agnostic framework to allow us to adapt to the different needs that we have as an organization, and we pull on the different work streams based on the specific needs that we have. We found this work to be very successful for us. We've been using it for about 3 years, and we're always looking for ways to enhance and to upgrade it as our organization continues to evolve. And then just, I think, very high level, what has been sort of our viewpoint of quality reporting from the lens of Northwell Health. We're looking at quality reporting really from the importance of understanding that it's not just getting the data to the CMS or to whatever agency we're working with in terms of reporting. So on the next slide, we put together some very brief sort of tenets of that we follow for improvement. Very critically important is this concept of monthly scorecards. People need to know where they are. We'll talk a little bit more about why that's important, but that transparency is key to driving change. People need to know if the things they're doing is working. If it's not working, right, we got to try something different. Then as we go through this work, we work very closely with offices or practices that are not doing well. And what does that look like? We create action plans, right? We give them very small but achievable goals and work with them either hand in hand with our team or with our partners out in the operations or clinical teams to improve their performance. Then we make sure that we have some forum where our clinicians can learn from each other through peer-to-peer discussions. We found that to be the most effective way to drive change, especially among our clinician work group. We then also want to make sure all those lessons that we've learned locally are shared more systematically. So we develop what we call a learning collaborative, where we take the different groups of folks that we work with across the entire organization, because we're structured regionally, and we share best practices. So folks understand what worked in one area, maybe it can work in another area, or maybe they have to make some local adaptations. But equally important, we also shared what potentially doesn't work, just so that people are aware of some pitfalls and they could potentially avoid it. And then while we go through all this work, it's critically important that we have a recognition program, because accomplishments are important to recognize, and small wins are what drive the energy to getting people excited about this work and stay engaged throughout all the different stuff that we're doing here at Northwell.
Great. All right, Ramsey, thank you very much for that. Let me stop sharing the screen so we could see all of us here. And let's get started with some questions. And audience, please feel free to ask some questions, and we'll try to get them all in. So my first question is going to be over to Aman. Aman, can you share how Northwell has evolved its approach to measuring and improving quality over the past few years?
Sure, Mike. So over the past few years, we have really shifted from a fragmented reporting environment to a system-wide data-governed approach. So earlier, every practice had its own way of tracking quality. There were different dashboards using different definitions, and it was just getting too complicated for us to analyze. So we realized that to drive true improvement, we needed to standardize the framework first. Through governance, especially our AQUIC model that Ramsey spoke about, we brought leadership, analytics, and operations all under one umbrella. That alignment gave us a shared understanding around quality and made it possible to move from just reporting quality to actually managing it across the organizations that we do now.
Great, thanks, Aman. And you know, Jared, to follow up on that, can you share what were some of the key drivers behind your focus on leveraging data to improve those care outcomes?
Absolutely. There were several factors and key drivers that pulled us towards data-driven care. First, I would say would be scale. We needed timely, reliable visibility across all of our practices, and that's in the hundreds now. And that would help us to understand what's actually happening in as close to real time as possible. Second, I would say actionability. Data isn't useful if it doesn't prompt us to actually act on it. And third, we needed trust and buy-in. Clinicians and leaders and stakeholders are more likely to act when the data clearly reflects their reality. When we take all these together, these drivers set the stage for turning these measurements into real improvements and patient outcomes.
Great, thanks, Jared. And you know, you mentioned you know, so many different practices, now over 100, which is incredible as your group continues to grow and grow. But with growth comes complexity, and Aman, how exactly, are you really dealing with that complexity with these multiple EHRs and billing programs and different supervisors at each location? Go a little bit into that if you don't mind.
Sure. Mike, this is definitely still our biggest complexity. Multiple EMRs, custom workflows, and a lot of variation. So our solution was to standardize measure definitions and build crosswalk across systems. It was a shift towards the system focused culture, moving from practice level mindset to a comprehensive system level approach. To accomplish this, we partnered closely with IT and Health Monix to make sure the data fields and logic match CMS guidelines. HealthMonix played a major role in helping us validate, test, and ensure consistency across sites through feedback reports. And Wallace here knows the best. We have requested multiple reports from him to ensure we have the right data in front of the right audience.
So Wallace, you for those who don't know, Wallace has been the account manager and run the program since Northwell has been associated with us. I think we're going on 5 years, maybe something around there. Wallace, anything to add on how you help them when it comes to complexity? Oh, I can't hear you, Wallace. Sorry, we'll come back to you. Just give me a cue when you're back online. All right, when you have voice. All right. So you guys have explained a lot about how difficult it is, how complex, 100 different kinds. What about? I mean, how do you prioritize? How do you know who to go after first? Is it the low-hanging fruit? Is it something like that? What do you see there? So, Jared, if you don't mind, if you want to take that one, that'd be great.
Sure. Yeah, it's a big beast to tackle of how do we get all this in one place. We start with measures tied to our value-based goals, things like Ramsey was saying, hypertension, diabetes, some of those horizontal work streams, where we feel that the impact will be the greatest. Then we sort of assess data completeness and readiness, right? If the source isn't reliable or ready, it won't be able to drive better care. So we need to take that into consideration as well. And then finally, we also consider EMR footprint and ease of extraction, meaning how much makeup does the EMR actually make of our big system, and how easy and ready is that to even extract. So we focus on prioritizing some of those large, high-impact sources like TouchWorks that made up a large portion of our EMR footprint. And then we sort of sequence in the rest as we gain the quick wins and confidence of the data along the way. So in short, big impact, reliable data, feasible extraction, and then sort of iterate from there.
Great. Thanks, Jared. Hey, Wallace, we got you back on? No. Well, we'll just keep him for his beautiful face. So thanks for thanks for being here, Wallace. So Aman, into the same thing. What lessons have you learned? I mean, this has been, this isn't something that developed overnight. This is something that developed over a number of years. From the beginning to where you are now, what are some of the key lessons you learned?
That's a great question, Mike. So in my opinion, the biggest lesson is to start with data governance before technology. Like strong leadership and collaboration will solve more problems than software ever can. We also learned that perfect data doesn't exist, but trusted data does. So transparency in how measures are defined and reported builds strong buy-in from the leadership. And having the right people in the room ensures that what we are building actually works in the real world.
Great, thanks. And we actually got a question in from the audience, and I think it fits in here instead of waiting till the end. Jared, how did you get buy-in? What processes did you use to accomplish them? Was it top down, bottom up?
So we actually realized that getting the data in a better quality area, more accurate, and feedback actually led to that provider engagement. Once we realized that measures were more accurate and the feedback can arrive sooner, clinicians were able to act sooner. An example of that would be like in our depression screening. Once we realized that the data quality increased, it led to clinicians being able to act and patients being diagnosed and treated when needed. The this transparency in the data also helped drive like our MIP scores, and providers were able to see clearly the impact of their work. And as we've been saying, it's a lot about the visibility and transparency. When clinicians have that real-time insight, the engagement and ownership naturally follow.
I would add one other thing to that, Mike. I think to build off of what Jared said, also important is when you do have that sort of transactional or discussion with them, when you're going back and forth and having that parlay, it's critically important to hear what they're saying in terms of feedback. Take it back to the teams and make the requests, the enhancements, the changes, or maybe the custom reports, depending on what they're looking for, because we want to make sure that they understand this isn't really a top-bottom. Northwell doesn't have a sort of top-bottom approach. It's very sort of horizontal in terms of responsibility. We're very matrixed as an organization. So when we get that feedback from our clinicians, we take the feedback very seriously. We work with the teams to ensure that we can deliver on what they need so that they feel like they can be successful.
Great. And, that leads right into our next topic. And, our next topic is going to be more around performance, improving performance. What do you do for that? And, you mentioned, listening to your physicians, and that helps gain some momentum in making those improvements. But how do you motivate these clinicians to participate in these programs? I mean, that's really hard. So Aman, you mind grabbing that one for me?
Sure, I'll build off Ramsey's and Jared's answer. So we really found that clinicians engage when they understand why it matters. So instead of framing MEPS or quality as a reporting burden, we tied it directly to patient care and recognition, which is the basis of the MEPS program. And leadership made it mission critical by connecting it to incentives. We also started a great recognition programs for high performing providers, like our AQUIC recognition initiative, in which we recognize providers for their efforts to increase performance.
Competition, Mike. It's competition.
When I consulted back in the day, I used to stick a scorecard up on the nurses' station in the practices, and usually it's like, well, why am I rated there? Would definitely help out with that. So completely get that. How do you translate the performance initiatives and data insights into sustained behavior? How do we keep that going year after year as the program changes, as your needs and your customers changes, more measures get added? How do you sustain that behavior on the practice level? That one's for Jared.
Yeah, so sustainment's hard. It's difficult, but as we've been saying, it starts with visibility and trust, right? We work with our leaders and clinicians to build these reports as well with Healthmonics, led by Wallace, to get these sort of feedback loops to keep the momentum going, right? So when clinicians are aware of where they stand, they can really impact that change. And then, as we were saying, we do lean on that peer benchmarking, that competition, to reinforce this in a positive way, to sustain that motivation and momentum. People want to naturally compete and compare themselves, especially clinicians. And as we were saying, we also like to celebrate the wins with that formal recognition program through AQUIC and through learning collaboratives, where we can sort of share what worked, what didn't work, and just spread the knowledge around.
That's fantastic. And I'll add in, since we can't hear Wallace right now, but I know he spends a lot of time really working with you guys to understand all the way down to that bottom level, to the provider level, so that you're not looking at a practice of a couple hundred doctors or something like that and not knowing where the weaknesses lie. Being able to dig down to the bottom and see, okay, these types of providers or this type of group aren't necessarily doing what needs to be done. I know specialists have always been, how do specialists work on that in this area, and it ends up really, just understanding that it's a team job. Everybody from your organization, top to bottom, needs to be involved in performance improvement and bought into it. So I think that recognition program is pretty neat, and something that you should be very proud to have as part of your team. We're going to move into the next set of questions, and really, I want to hear you guys talk about what lessons are learned. So Aman, how has data-driven clinical improvement. I mean, in the end, I mean, we could sit here and talk about the percent that you get back and meeting the goals and things like that. I know for the MIPS world, we just found out how much the 2024 got back. But in the end, it's really about that patient. It's about did the work that we've done help that patient improve? So if you want to start us off with that, that'd be great.
Sure. So reliable data gives clinicians confidence in their work, and when they trust what they see, they are more willing to act on it. And over time, that trust turns into a feedback loop, as Jared mentioned, and data leads to insights, and insights drive change. We also found that telling the story behind the data, not just showing the numbers, really helps the clinicians understand what they're doing. For example, we can't go to the clinician and say your hypertension performance is not that great. We look into it and we identify that your hypertension compliance is not that great, not because the patients are out of control, but because majority of them don't even have a blood pressure documented. So it's an easy fix. Just call them in and send a reminder, hey, come have your BP checked.
That's great. And I know in the end, you're going to start seeing impact from you guys have enough of a footprint in your geography that there will be an impact to these programs. And that's always made, I've been in healthcare for a long time in healthcare data. And one of the things that I love working with an organization like yours is that there's actually a feel that we're helping people at the end more than I'm just playing with someone's data. And it really, empowers me and empowers Healthmonics to drive performance improvement within our organizations, because at the bottom level, you save a life, it can help someone get out of some trouble, it can make someone's life better if we're all working together. So that's kind of really neat.
Mike, if you don't mind,
yeah,
I
go for it.
want to
Yeah.
share a very quick patient story related to what you're talking about. I think it really reminds us why we do this work. When Northwell launched our system-wide depression screening initiative in 2024, and we kind of started some of this work in 23. We'll talk a little bit more about the planning for 25 later, but just a preview of this is we were trying to figure out how do we do this work at scale across a large geography, across so many different specialties, et cetera. One of our groups out in the city, specifically urology, told us a story of how when they went to screen a patient, the patient told them they were not feeling good, that they had ideas about hurting themselves. And it was through this initiative that group realized how important it was. This wasn't just a metric. This was about making sure that we treated patients holistically and had that whole patient care and addressed all the different things that probably would have been missed if not for these types of initiatives. And when we have stories like this, they become very powerful reminders to not just our clinician groups, but everyone who works in an office, that you play a role in how this work plays out. And then now you get to see how that directly impacted patient care. And it was a very powerful reminder for the different groups that we have in that area that we just saved a life by doing this work.
That's fantastic. I mean, that really makes what we do, really impactful and meaningful. And those types of stories are great to share. And I always love hearing them. So thanks for sharing that. I hate to jump back into something not as deep as helping patients and so forth. But one thing that comes across, especially in the world of EHRs and some of these quality programs, is the consistency in the data that you see, as well as the completeness. It's not easy. You have multiple answers for many of these questions, but a lot of times it's not that you didn't do the work, it's not in the right place, or it's not calculated, or you did a depression screening, you did the follow-up, but the doctor wrote it in the note instead of documenting it where it gets picked up. What did you do early on to overcome some of those data consistency and completeness issues, Aman?
Sure. As you mentioned, Mike, early on, there were inconsistencies in the EHR. There were a lot of EMRs that we had. There were different data fields, custom templates, and you name it, we had that issue. Some measures were underreported because the logic didn't match CMS definitions. We fixed this through validation rounds involving clinical and ID teams to make sure we are pulling from the right fields. We also reduced redundant documentation workflows. which cleaned up the data significantly, like providing clear guidelines to only enter data in fields which can be reported or pulled electronically. That means no free text documentation was allowed. It took us time, but that's how we build trust in the numbers.
Great. I used to joke around as like, you're not getting MIPS credit if you have the picture of the smiley faces and one circled in a document. It's not that easy to figure out how that gets into quality data reporting. So what are some of the common pitfalls, especially understanding the CQM logic? You know, they change every year. You know, it's like, you know, you get the final rule comes out and measure 134, you know, for depression screening, only bipolar disorder is what gets you out of it this year. Or the age range for breast cancer screening is different between the different measures. You know, there's lots of changes. So Jared, what are some of the common pitfalls when it comes to logic and CQMs?
Yeah, to sort of build on what we've been saying, and especially what Aman just said, like one pitfall is assuming that this vendor logic will automatically align with CMS definitions that are constantly changing, which is why we had to implement some of these internal validations. Misaligned workflows improve when we bring the right staff, clinicians, IT staff, vendor, project managers, bring them all in early to map how this data moves to the reports. Like, as you were saying, the reality that what's documented in the EMR isn't always what shows up in these reports that get prompted to us. So that's why it was important to start this validation process, so that with the people that are actually using this data, to accelerate this adoption, we moved away from sort of the jargon, and we started to simplify the visuals, align terminology, so that everyone shares this same understanding, that same, the same understanding.
And I would add to that, we had to do this across many different EHR systems.
Yeah,
we had, yeah, right. So for this exercise, every EHR, we have to do that exercise. And then when you commingle all the data, then you got to do it again, right? Because who knows what happens when you start commingling data from different EHRs. So it was a labor of love, but we learned a lot along the way, and we had the right folks in the room, as Jared said. And I think that's what helped contribute to us getting to the point where we feel very good about the data. We trust it, and the people we work with trust it as well.
That's fantastic. You know, in the end, you know, there is a lot of information when it comes to these measures that gets misconstrued over the years, because a lot of these providers, like, I'm providing the same work, the same level of consistency, but you're changing you're moving the goalposts, we like to say, of what I need and what I need to do. And, you know, it does come complex. Measures moving forward, they're adding some that, you know, haven't been part of the normal CMS web interface back in the day. And lots of changes going to need to come when those come out in a couple of years. So let's move on to our next topic, and this one's going to be how did you prepare for 2025? What are the plans moving for 26? You know, and I'm going to throw this one right over to Ramsey to start. But how is Northwell preparing for the 26 program? I mean, the final rule just came out. No surprises. You know, there's a couple changes. It basically said, "Hi, this was the proposed rule. We listened to everybody complain about it. We're implementing the whole proposed rule." Where are you guys with 2026 and planning for it?
Yeah, I think a lot of people were hoping that CMS would probably pull the trigger on CQM or ECQM reporting, but I think over the last couple of years, we've realized that was the direction they were moving in. So we've always had this in mind, that this is the direction we would have to move in. So the work for preparing for 2026 actually started many, many years ago when you and I first started our conversations around how this work will look many years later. And here we are, right, Mike? It feels almost like yesterday. But some of the things that we've done, you heard Aman and Jared speak to it, right? It was very important that we took inventory of all the different systems that we had in place. We understood what the systems were capable of reporting, how they were capable, right? Some systems tell you they can do QRDA document extracts. You get a QRDA document, you look in it, and there's nothing in there, right? So then we have to be able to adapt. So one of the things that we've always kept in mind is there needs to be adaptability on our end, right? We have to be flexible with how we're extracting data, how we're making sure that we have data completeness in the different systems. So we realized that we were going to have to take a mixed approach, right? For some systems, we're going to do QRDA1, documentation collection, and then some of them we're going to have to do custom extracts. So it was really important that we had sort of a consistency in terms of the definitions, but variability in how we got the data that we needed to collect. We also, with the rules that come out, we really look at it in terms of like an input into the strategy, not necessarily a disruption, right? We anticipate year over year, there are going to be potentially changes that will require us to flex and adapt. We try to do the best that we can in terms of anticipating it. We're not always successful, but we have a strategy in place that is flexible to accommodate some of those design inputs. I will say I was very excited when I saw the final rule come out. It was a late evening of reading, but nothing dramatically different in terms of what I've read so far. Disclaimer, still need a little bit more time to digest it, but we're very excited about what we're seeing. And something we didn't even talk about on the here so far is Northwell is also undergoing an EMR transformation, right? We are moving.
I wasn't going to mention it. I wasn't going to do it.
I'm mentioning it. We're a day, I'm trying to look at the calendar. We're like day 5, I believe. It's, going well, but here we are, another sort of EMR to pull into this process, right? And then not just making sure the sort of the back end components of this work, the value set mapping is going well, the front end workflows, how are our clinicians liking it? How do we train people to make sure they feel comfortable with doing the work, where they have to go? What does reports look like? So this is almost like deja vu, but we've had the prior experiences of doing this work. So this becomes sort of another item that we have that we can lean on in terms of preparing for Epic. So that's a very big focus for us going into next year, while we make sure that we have all the different pieces together to ensure that we can report and meet the data completeness reporting requirements that we've been sort of focused on very heavily over the last year.
That's great. Thanks, Ramsey. Wallace, you with us?
I believe I am.
Yeah, there you go. I want to throw it over to you because, Healthmonics has done some things to prepare us for 2026. You want to give a kind of a sneak peek at what we're working on to help our clients just like Northwell?
So clients like Northwell are usually complex, lots of different data sources, lots of data flowing at once from different sources, different patients, patient matching, things along those lines. What we're doing here at Healthmonics, partly one of the main things we're working on now is ensuring that we can get their data in sooner, faster, more efficiently. One of the ways we're doing that is we are working on some new offerings within Healthmonics that will allow them to start really looking at their patient visits and encounters as early as January 2026. For the current year. A lot of times you'll notice that some of your organizations like a Northwell will begin to look at their data after submission in March, and we start looking at data sometimes, May, June, July, start getting data in for the current year for 2026. But this year we're going to be looking at those visits in January, giving real-time decision-making, clinical decision-making opportunities to these physicians in the early first quarter.
Great, thanks, Wallace. I'll add on to that too, is that many organizations, Northwell, are making decisions on these programs and who's in and out of an ACO. And, we have specialty groups here and so forth. And, all your data is in one spot or 10 spot, or in your case, 100 different spots, right? But you want to separate it out. And, there are complexities not only around the MSSP ACOs, but we also have clients here on the Reach ACO where they can basically pick and choose inside of a tin who's associated with what quality reporting program. So some of the advancements that we're doing on our product are really, I like to say we took Northwell as the example to really build out what we're trying to do here, and they've been a great partner in providing us the most complex way to bring data in and the most different EHRs and so forth to help us gain where we are.
And Mike, I would add just one other thing that I think we found really helpful in working with Healthmonics is yes, we have an ACO. Yes, a vast majority of our clinicians are in the ACO, but we have pockets of people who are not. So we have to be able to balance what the MSSP requirements are, the APP plus measure set, but also at the same time, what the traditional MIPS or MVP requirements are. And working with Wallace and the rest of the team at Healthmonics and the Northwell team, being able to balance all those different requirements, all those different programs, has been excitingly fun. I say that slightly as a joke, slightly as not a joke, but it really adds, I think, to the importance of folks understanding that this work is complex, but once you have structures in place and good partners, you can find that you can be successful in them.
Great. Something that I wanted to actually bring up, and I don't know if you got to it in the final rule, but it was proposed and now been finalized that they're changing how they're going to say who is on your roster for Medicare CQMs. I think that's the biggest impact for ACOs moving forward. Now, you guys have tracked both Medicare CQMs as well as CQMs. Is there a difference in your approach when trying to look at that stuff, or is it just, hey, that's Medicare CQMs are great, I'll keep it on the back burner as another option?
Yeah, I think that's kind of how we're looking at it, right? We're looking at which approach do we believe will allow us as an organization to be the most successful. And there's sort of, I think, sometimes surprises that people have, right? Some folks, because of Medicare CQMs being inherently focused on the Medicare fee-for-service population, think naturally some of their metrics might just be higher, right? And then you look at your ECQM performance and you're like, wow, actually, we have better blood pressure control in our ECQM performance versus our Medicare CQM. So I think, again, it's interesting to kind of look at the different reporting frameworks, understanding what's sort of contributing to each of them, and understanding which one will lead you to being the most successful is going to be how you want to approach it. But there are considerations, right? If you're complex, multi-TIN, multi-EHR, it is more work to have to go through the data collection, aggregation, validation, testing process to go to every EMR, where Medicare CQMs might actually limit which EMRs you have to potentially collect. So there's some sort of pros and cons to both. But if you have the capability to do reporting and look at it across the lens, I would strongly encourage it and pick the one that leads you to being the most successful.
Right, and CMS actually allows you to report it all, and they pick out the best one. So, it does make that it's one of their policies that I love is that you can report anything you want, and they'll take the best answers to give you your score. So, Aman, where do you see the greatest opportunities within the value-based care analytics area as we move forward? In a scale the size of your organization, sometimes you have to look at the numbers and see where they go and what needs to be done. But CMS is pushing towards DQMs and pushing towards some other programs. But where do you see innovation in this whole mess that we're in? Lovely mess, sorry.
Yeah, that's a great question. Interesting question, Mike. So I think the biggest opportunity lies in moving from descriptive to predictive analytics, meaning using data to anticipate issues rather than just reacting to it. And integrating diverse data sources like social determinants of health and patient experience is another opportunity. And I think CMS is also moving towards them. And of course, will be a prerequisite going forward. The data sets are becoming too large for to handle. And I believe the next evolution will be real-time insights at the point of care, where analytics can actually guide decisions as they happen. But I think we are far from it at this point.
Yeah, no, it seems like there's definitely words that have always come through the industry 4 or 5 years before they become reality. MVPs are an area where they talked about it 10 years ago and really became a reality later on. Interoperability was the big word, for a long time. But on that loop, Jared, how do you see your use of data evolving, utilizing some of the things that Aman was saying?
Yeah, just to sort of build on it, we're definitely trying to shift to as close to in real time decision actionable feedback as possible, right? At that point of decision making instead of reactive, to provide that actionable feedback that teams, clinicians, leaders can use now, with robust benchmarking, both inside our system and externally, to define what is the best practice. As Aman was saying, analytics will have to become prescriptive, and we'll have to use AI to recommend those next best actions. We'll try to integrate predictive insights so that we can intervene earlier and prevent those gaps before they even occur. The goal is proactive, data-driven care at the point of the decision.
Great. Thanks, Jared. And right now is a great time for an audience. If you have questions, we have a couple more things I want to go over, but if you have some questions right now is a great time to pop in and ask them. But I'm going to pivot over to Ramsey. Ramsey, you just attended NACOS a couple weeks back. It is the largest gathering of ACO super minds in the world. What were some of your insights? What do you think's happening? Where do you think it's coming from?
That's a really great question, Mike. I think I learned a couple of things from NACOS, and I always enjoy going there every fall. One of the things that I think was pretty apparent, and I touched on it earlier, is that ACLs and just generally speaking, value-based care is viewed very favorably by the current administration as a vehicle to help bend the cost curve and build sort of more accountability and reduce some fraud, waste, and abuse, as they put it. And what we're seeing is that there is more interest in exploring what some of those models can look like. You also saw it in the final rule, right, where they're looking at lower back pain as one of the conditions to potentially treat as sort of its own little MIPS group, as a bundle kind of care program. So I think what we're going to see is more interest in this space around how do we tie cost, quality, and some other initiatives together in these programs going forward, with a specific emphasis on specialists. There was a lot of chatter that most of the programs till date have been focused mostly on primary care. And when you try to take a primary care program and push it towards specialists, it just doesn't work. So I think we're going to see more experimentation in the specialty fields in these areas to sort of bring cost and quality tied closely together. And there seems to be some real push to apply some downside risk, right? So there's potential financial ramifications that could come from some of these changes. I think another thing that I saw really interesting is as this work becomes more and more complicated, historically we used to hear this concept of, do you build the solutions, the products, the teams that you need, or do you go and buy it? And what we're seeing is an evolution of that, what I like to call sort of a hybrid approach. There's this cross-functional approach where large organizations are now partnering with vendors, exploring ventures to tackle or create new solutions and offerings that can help prepare organizations on value-based care. Again, you not any one organization has all the tools and resources, but you can build it. You can build the capacity through, as I mentioned, through some of those partnerships. And I think another thing that we also see is more cross-functional team building in NACOS. It seems like every ACO that I speak to has a model where there is a strong clinician or clinical lead paired with an administrative finance person, and they understand that the two sides to the formula, right? Simply put, how do we manage good quality of care for our patients while also being cost conscious and working collaboratively between those two leaders to help drive value-based care themes that surfaced during my time at NACOS.
Great. I always enjoyed my time. I look forward to hopefully being able to go again next year. And it seems the information shared at NACOS is, the one thing I really loved about it is that you could be sitting next to someone who is running another ACO and you just share. It's not the same. It's not competition. It's how do we do this better as an entire group, and how do we get better? And that's always neat to me when you're talking about different organizations across the country and have different patient base populations, different EHRs, different everything, and how they're dealing with it. You could learn a little tiny thing from someone. Hey, we do this, and the collaboration's great. So we do have a couple of questions here from the audience. I think we're getting to it right on time of where we wanted to have, but I'll ask the first one, and I'll point this towards Jared if he wants. But what has the practice done to help the documentation for numerators across different EHRs? Are you working with the EHRs to map the fields that we need, or how are you dealing with that?
Yeah, so that talks to sort of our validation process that we had to build when we partnered with stakeholders and leaders from the individual EMRs. We would have to basically go into it and be like, this is what I see, what do you see, and what is on HealthMatic's side, what's on the EMR side, and make sure that the two are talking to each other. And if they weren't, that's when we would tap in some help from our friend with Wallace here, and we'd make sure that we can build it correctly and make sure that it was mapped correctly. Sometimes it was about reducing entry points of how many different ways is it to enter this one piece of data of, let's say it's a depression screening, right? And we had to simplify that and reduce the amount of variability across the board. It's a lot of back and forth to build it and across all the different EMRs that we had, but it was good partnerships that we had.
Great, thanks, Jared. So something that, it was a question asked in a different way than what we talked about. We talked about how do we motivate our providers to join and to do what needs to be done. Question came is, how do you deal with groups that don't want to participate to the level needed? And I mean, how do you work with them? Because it's not like it's easy to just say, hey, bye, you're out of the ACO. What do you guys do to help motivate those that are not living up to their peers? So I'm going to open that. I don't know who wants to answer that one.
I'll take that one, and Jeremiah can jump in. I think what you find, at least in my experience, is people tend to want to do this work, but there's usually a barrier, an obstacle. And sometimes what they tell you what the barrier obstacle is not necessarily what it actually is. And the only way for you to find that out is to, take your suit off, walk into the office, in plain clothes, talk to the medical assistant, talk to the nurse, right? Talk to the physician, understand what their pain points are, right? Understand what's the barriers that's generating all the resistance to doing some of this work. And I think you find more often than not that once you're able to really address what their key concerns are, they're willing to really support the work. But that takes time, that takes dedication. Here at Northwell, we have a pretty robust, strong team led by one of our senior directors, Chris Delinsky, whose folks go out to our offices every day. They go out to multiple locations. They have built relationships with the folks, both employed locations and our voluntary providers. And we understand what is driving them to resist this work. And we work very closely with them on that. And again, different motivations sometimes for folks. We find that perhaps incentive programs work. Sometimes recognition programs might be effective, or sometimes docs just need extra handholding, right? They just want that extra dedicated training. So we'll go out there, we'll sit with them, we'll show them the processes, we show them the workflows, we teach them the reports. And once we find that the resistance tends to drop significantly from there. But it is a time-consuming process, and I think you need to give yourself and the teams that you're working with a little bit of grace to understand that it's not going to happen overnight.
Great. On top of that, one thing that was really important a couple of years ago, and definitely is coming up, and someone's asking a question about it right now. That's newer to their newer ACO. One of the biggest issues was those not employed groups, but the other groups that are out there, and you saying, hey, I need all of your data, not just your Medicare data. That was a big argument. I haven't heard as much lately, but can you share some of what you guys did then to really drive the saying, hey, no, we need all of this data, not just your Medicare patients?
I'm laughing, Mike, because right before this, I just got off a call with a gastroenterology office, and they're like, why do you need my depression screening data? And I'm like, we've talked about this 1,000 times, guys. Come on. Yeah, it's almost like there's this sort of sense, especially from your community partners. Oh, like, what are you going to do with my data? Where is it going to go? I'm really worried about these things. And almost like you sense there's distrust. And I don't view that necessarily as a negative thing. I think that's actually a good thing. They're not just going to open up their EMR and say, hey, here you go, right? Back to what Aman said earlier. People need to understand the why, right? Did we as an organization do an effective job at explaining the why we're asking for the data? Do you understand all these changes, these regulatory changes that were introduced by CMS? We've been talking about it for 3 years. But what you also find sometimes is you did a good job, but guess what happens? There's turnover, right? There's a new team running the practice. There might be a new practice manager, a new physician lead who may not have been part of the original group. And that's why that consistency and communication is key. And it's funny, I had my conversation, I explained to them the why, I showed them the email chain, sent them some of the recordings that I've shared with my team. We have our ACO director talking to them as well. Again, once folks feel and understand that they know what the why is, you start to see that they're okay sharing the data. And that's really the only group that we've received any resistance from so far this year from doing that. But I will say, Mike, one thing to think about is, hopefully you're collecting that data, because some of them may not resist giving you the data, but when you get the data, you realize there's going to be some work I have to do to get it scrubbed and clean and ready for reporting.
Right. No, terrific. I know there's still, there's still groups that when we talk to that they still are like, yeah, I did it for all my Medicare patients. What's the problem? I did everything I was supposed to do. We still here at HealthMonics, sometimes even for our MIPS providers, get people that are like, well, when did MIPS become all payer? And I have to answer 2017. And it's time we move from there.
Yeah.
So with only 10 minutes or so left here, I wanted to ask you guys a couple questions, and one of them is, you guys are going through this Epic integration, and you are also going through an expansion that is, I don't know, not doubling the size, but a significant increase in the size of your population. How do you handle all of this when there's so much noise coming in from a new EHR, from a new program, from an updated this, from a new group joining? How do you guys prepare for expansion?
We work 24 hours a day, Mike, 7 days a week. It's not that
I know.
complicated.
I've received your email, so I understand that.
I'm sure Armand and Jared have thoughts. From my lens, it's really about not letting the big picture overwhelm you, right? I very closely with our leadership team, and we prioritize, right? We do a lot of, Jared's laughing because we do a lot of matrices, right? What's high effort, high value, what's priority, what can wait, and we do a really good job at managing expectations, right? We can't do all the work now. We would love to, but it's just not feasible. So we work very closely with our leadership to determine where the priority is, what's the now versus what's the tomorrow.
That's great. Amon or Jared, anything to add to that?
Sure. Like as Ramsey was saying, it's sort of goes back to what I was talking about before of just like, how do we get their data, right? We have to put on the blinders to all the noise and just like take it step by step, put on the like prioritize it, get the right people in the room, and slowly but surely it comes together and you build that trust and accountability, and that goes a long way.
Great.
Yeah, and just to add to that, like when we talk about strategy, like we obviously feel there are a lot of distractions, but once we have our goals from the leadership, it makes us very clear, okay, we need to focus on these things. Rest is just no. Sorry, was I disconnected?
That was two.
Yep,
Did we,
buddy, got
did we drop?
Okay.
I think we're back.
So I think we're back. And
Yeah.
hopefully, I believe it was a bit on the hey, who knows? I think we all got disconnected. But
Yeah, we did.
so let's just finish this off, guys, with one last question for everybody. And if you had to pick one thing that drove your success in this program, each one of you, what would you pick and why? Let's start off with Mr. Ramsey.
Great partnerships. I think when I think about what we've done here at Northwell, there's so many names for people, and I'm gonna get yelled at tomorrow for not naming all of them. But dating back to conversations I had with main PM Peter, currently Michelle, Jared Amon, the rest of the internal crew that we work with, the people who go out to our practices. I mentioned Chris Delinsky, our partners out at the practices who run the operations, our IT team, really just people being sort of aware and understand the importance of this work, bought into the big picture and really understand the mission, and just working collaboratively has been, I think, the secret sauce to our success.
Great. Thanks, Ramsey. Who wants to go next?
Sure. Like I think adaptability is a huge one for us. Our regulation CMS guidelines, our EMR systems and expectation, they keep on changing. So we try to be flexible and adapt to those changes.
Great, thanks, Amanda. Jared?
I'll add one that we've been talking about basically this whole time is just the trust before the accountability, right? We needed to build trust that everyone understood the data and that it was reliable and that it was what we were seeing in the field versus just on this back end. Once we built the data that clinicians and leaders believe, that's when the accurate, timely decisions of at the point of care can start to happen. And that's where we start to build the accountability, right? Once we invest in this governance, the common language that everyone's speaking, we can really start to build that accountability.
Great, thanks, Jared. Wallace, any parting words?
I would say, Jared pretty much hit the magic word, accountability. Northwell is very big on having the difficult conversation. They hold their clinicians accountable to drive patient outcomes and quality of care, and they hold us as their vendor, accountable to efficiently and effectively ingest and calculate their performance and show the results, right? So they can use that for real-time clinical decision making. So having those difficult conversations is a core part of the success they're having.
Great, thanks, Wallace. Wanted to end it here. Aman, Jared, Ramsey, Wallace, thank you so much for joining us today. I think this was a great conversation. Hopefully we get to do it again soon. I appreciate the partnership as always with Northwell. And if everybody, when you sign out, there's going to be a little survey at the end. Please provide your feedback because we want to make sure we're providing the right things to our audience. Guys, thank you very much. Have a great rest of your day. And we look forward to catching up with everybody soon. Much appreciated.
Yep.
Thank you, Mike.
Thank you, Mike. Take care, everyone.
It was a pleasure.
Bye-bye.
Bye.